Assalamu alaikum. My name is Maya Zubair. My roll number is PP165021. My group is 8 and my topic is neuropathic pain. So there are two types of pain. First is nociceptor pain and the second is neuropathic pain. In nociceptor pain, there is a damage to the brain of the tissue and it starts releasing all sorts of chemical signaling molecules that stimulates the nerve and it sends to the central nervous system and that creates a conscious sensation of pain. Whereas in neuropathic pain, the injury is not to the tissue of the vein, but it's actually to the nerve itself, and this type of pain is recognizable clinically. Neuropathic pain can also be caused by the damage to the somatosensory system, and it can be an ongoing pain. So the causes for nociceptor pain can be mechanical, cutting, stretching, thermal, chemical inflammatory, post-operative or post-traumatic, and the whole point of this system is that it points us about the tissue damage. Whereas the causes of neuropathic pain are infection, shingles, nerve trapping, physical pressure on the nerve, trauma, or diabetes, HIV, and alcohol can cause peripheral neuropathy. It means they will start generating nerve impulse when they are not supposed to, and it will go up this pain pathway and being interpreted as pain. Neuropathic pain can also complicate stroke, chronic inflammation, and cancer. And chemotherapy can also cause neuropathic pain. So, how do we recognize neuropathic pain? So, it can be constant or paroxysmal. Paroxysmal means that it would come and go. There would be burning, stabbing, shooting, lancinating, numbness, tingling, electrical sensation. All these indicates that the pain could be neuropathic. There could be anesthesia dolorosa. It means if the area of the skin is not sensitive to touch, the person can't feel it, but there's still pain. There could be allodynia, which means very light touch will stimulate pain, so touching the surface of the pain will interpret it as a painful stimulus. Now, how do we manage or what are the treatments for neuropathic pain? So, nociceptor pain can usually be treated with analgesic, but very often analgesic don't work with neuropathic pain. If possible, we treat the underlying causes. Very often, we might give amitriptyline or duloxetine, and these are increasing the amount of norepinephrine and amount of serotonin in the synapses in various places where duloxetine is an SSRI and amitriptyline is a TCS and a tricyclic antidepressants. Then we have gabapentin and pregabalin, which are anticonvulsant and they affect the amount of chemical substance GABA and it's an inhibitory neurotransmitter. Whereas duloxetine is a good example in diabetic neuropathy. We have carbamazepine, which is also another anticonvulsant, which stabilizes the nerve fiber as well as working on the synapses. It actually works on the sodium channel. We have tramadol, which also affect the neurotransmitter, so it's good for managing acute neuropathic pain. It's an opioid, so it should not be given for too long, so we can give it for rescue effect. We have capsaicin cream. It diffuses through the skin and actually affects the substance period that influence the nerve activities. So the case study. We have a 40-year-old, generally healthy woman suffered a superficial laceration of her left arm at work from a broken glass window. The initial laceration has since healed without complications, but now she is referred for evaluation of pain management because of persistent intolerable pain in her left arm and hand. Physical examination reveals allodynia in her left hand and arm. What caused the patient's condition and how would you manage her pain pharmacologically? So here's the soap notes. So its objective is that she is a 40-year-old woman and the main objective is that we have to manage this persistent intolerable pain in her left arm and hand. And through physical examination, it was revealed that she had allodynia in her left hand and arm. Assessment. Due to minor injury, there was hyperalgesia, but the pathogenic basis of such pain is not understood. So, in such patients, the pain threshold is decreased and the stimulus response in the affected region is increased. This persistent pain could be because of the associated reasons, which could be blood flow, osteoporosis, swelling, change in the temperature, and atropic musculocutaneous changes in regional temperature without demonstrable nerve injury. In the affected area, pain is elicited by even a slightest mechanical or thermal stimuli. This painful hyperalgesia condition is known as reflex systemic dystrophy or chronic regional pain syndrome. Has been attributed to sympathetic excess and has been called sympathetically maintained pain. So we have planned we have non-pharmacological treatment and pharmacological treatment. In non-pharmacological treatment, the first line non-pharmacological therapies are physical exercise performed individually or in group, initially under the guidance of a therapist and later independently at home. Gymnastic and breathing activities such as yoga and Pilates, cognitive behavioral therapy, mindfulness-based pain management, and physical therapy, such as magnetic field, analgesic stimulations, and vibration therapy. In pharmacological treatment, as you know that SMT may partially respond to pharmacological agents that interfere with the alpha adrenergic functions, therefore it would be expected to respond to clonidine, prazosin, phenoxybenzamine, and guanethidine. Some symptoms of these syndrome responds to other classes of pharmacological agents such as steroids, NSAIDs, TCAs, anticonvulsant, antiarrhythmics, or local anesthetics. Thank you.